Welcome to the Healthcare Cure Podcast, a podcast dedicated to the bold mission of fixing healthcare. Now, here's your host, healthcare futurist, best-selling author, and adjunct professor, Nick Webb.
Hi, this is Nick Webb, and welcome to another episode of the Healthcare Cure Podcast. You know, in my career, I've had the opportunity to meet some amazing people and to learn from their journey. And that's what I love about this podcast, is to be able to really spend some time with some incredible people that are actually making a difference. And there's a name that kept on coming up to me over and over again when I started my work at the university, and it was Dr. Pakia. And Dr. Pakia is not a theorist. What he talks about isn't conceptual. It isn't ideas without foundation. He's a practitioner. And, you know, I read so much about the impact of technology and the impact of emerging trends from people who really are not seeing patients and are not living this on a humanistic level, the impact on the patient and the way in which we have this beautiful convergence between technology and emerging resources and the human. And that's really what I'd like to talk to Dr. Pakia about today. But what I'd like to first say, first of all, welcome to the program. And I'd love for you to introduce yourself and tell us a little bit more about your journey.
Nick, thanks for having me on board. Pleasure to be here. It all started about 35, 40 years ago. Off to medical school I went after looking at different careers, pathways. Was fortunate enough to be admitted to Michigan State University, trained in osteopathic medicine there, did postgraduate, moving back out west. I was born and raised in the greater LA area. Focused on primary care and met up with some folks in Orange County, California. Spent 25 years there in a private practice, private group practice, practicing in a variety of different settings, everything from standard ambulatory care medical office to the admitting of patients to the trauma center next door, and then in the outpatient or remote setting, nursing homes, rehab centers, house calls, etc. So was fortunate to have that type of experience prior to moving out to the desert area with a health system that was beginning the process of starting an advanced primary care model for its health system strategy. It started with 5 physicians there about 10 years ago now, with a view toward implementing a primary care residency program as well. And 10 years later, and 240 clinicians later, and 90 residents in training, it's been an interesting and informative run. So that brings us up to today. Thank you for asking.
That's terrific. You know, it's interesting. I remember you and I talking a few years back about the inevitable impact of telemedicine. And I think, we were both sort of surprised that the adoption of telemedicine was so slow. And it felt like that most people, when they thought about telemedicine, they saw the interaction in telemedicine of having some degree of sterility between the patient and the caregiver. And it's interesting. We were lucky enough to have scripts in our documentary film. And, you know, they were very much ramping up. They understood the inevitable benefits of being able to provide access to patients quickly. If somebody has a urinary tract infection, rather than sitting in the emergency room or in urgent care for hours, they could quickly see a caregiver, get diagnosed, and get intervention in a way that was frictionless. And of course, that's one of the big movements as we think about these 4 big trends in healthcare that I talk about in my upcoming book, The Healthcare Mandate, that'll be out this September, is that we see hyper-consumerization. Patients are demanding not just efficacious, safe, and beautiful care, they also want amazing experiences. They want it to be friction-free. They want it to be convenient and relevant. And of course, the trends of connection architecture and enabling technologies and new economic models and new business models. I mean, the entire landscape has changed. But in looking at Script, you know, they had been prepared for a very, very long time. They're a great organization, and they really built out a very robust strategy for implementing telemedicine. But, you know, you don't do it until you have to. And of course, COVID-19 came along, and they went from, I think, 4 to 5 telemedicine consults per day to something north of 3,000 a day. I mean, literally instantaneously. And from talking to their caregivers, what they found is that this is actually a pretty good way to deliver care in most instances. Now, obviously, some interactions clinically require, you know, physical contact and physical exam. But what's your take in the sort of telemedicine renaissance? Is this a good thing for healthcare in your view?
My experience with this is that yes and no, depending on what component of what we call telemedicine and the practice of it is how it's deployed and who's deploying it.
Yeah.
So my experience with the personalization component that you mentioned, and always the fear that digitizing a relationship of any sort, medical in particular, might put at risk what we call the doctor-patient relationship and that important aspect of it.
Yeah.
If appropriately deployed, and if the philosophy of care focuses on maintaining that relationship, I've seen that actually can be magnified. So the humanistic components of it, the intangible component of practicing medicine, once you knock down the barriers that are associated with, I guess we would call this the old school medicine, the medical model based out of medical offices, hospitals, etc. When components of that are replaced, made more efficient, and actually the patient and the doc or other caregivers are brought closer, including leveraging the capability to bring a team to bear for the treatment of the patient and the client, actually magnifies the relationship, and takes some doing, lessons learned, and takes leadership to recognize the importance of that, but properly deployed with the right tools and the right software environment, keeping in mind always the importance of security, confidentiality of the relationship and the data, it can go quite well.
Yeah, you know, it's interesting when we were doing the research with some of my researchers on the healthcare mandate, what we found is that when it's done right, the bottom line is patients like it a lot. It provides access to care more quickly. The other thing that we found that was kind of interesting is that, you know, the patients had this sort of mono, you know, view. There was no peripheral, nurses coming in. There's no traffic lights in the exam room. There's none of the pressures of that you would typically see in a traditional clinical setting. And for the caregivers themselves, a lot of them really like the idea of what they feels actually more one-on-one. It felt to them oftentimes like it was more of a personalized relationship. And now some of the technologies that we're working on, which is really exciting, is where we're actually able to use facial AI and facial colorization AI. And an area I'm very excited about, which is head movement AI, is understanding incremental movements of the head and their potential association with neuropathology is likely a thing. And the research is yet to prove that, but it's just begun. But when you combine it with voice AI and facial AI, we already have good algorithms to show that we can determine mood state. And so, you know, from our perspective, the future of telemedicine will be enabled by a dashboard on the caregiver side that'll provide information that's leveraging existing technologies like the camera and the actual microphone, because voice AI is actually starting to get pretty interesting. We can determine, inflection, modulation, pitch, key, pausing, the clarity of speech, and determine lots of interesting things. I think those algorithms on facial coloration, facial AI, voice AI, and head movement AI could add a lot of depth to the actual diagnostic pathway. The other thing is now we're seeing kits that are being developed that basically include an otoscope, an ophthalmoscope, a dermoscope, a device that connects to get acoustically listen to the chest. We have the ability to do all kinds of things with really inexpensive sensors because we're counting on the computer to do the computation. And all we need is really some pretty simple acoustic and optical sensors. And some are looking to be maybe $15. So when you get your health insurance, you get your kit, and that kit is available to plug into your smartphone or to your USB device. To be able to provide some additional diagnostic tools. That's one of the issues that a lot of caregivers are concerned about, is not being able to get better physical exams. Are you seeing the emergence of those kinds of technologies in your practice?
Excuse me. I am on an incremental basis. So as the technologies come along and prove themselves out as having value, and simultaneously, as the recognition of that value by the leadership of any particular medical group and the individual practitioners, their buy-in to the importance of remote patient monitoring, RPM, including the value of placing that important information, which is quite a bit of incoming data, onto an AI-driven clinical decision support system that's an always-on 24/7, 365 environment.
Yeah.
Absolutely can make a huge difference. The challenge is how to deal with and categorize and actualize that tsunami of data that's incoming, and how to design the AI piece to analyze that data so it becomes actionable. Everything from the ability to leverage that for wellness and preventive practice of preventive medicine, as well as the sort of the other end of healthcare, which is the ability to respond on a timely basis and be tooled up to deal with the separating the amount of information that's important and that which is not. So using examples of a patient who may become, may be on their way to becoming septic in geriatric medicine. A good example would be urinary tract infections. They are common, they're varied, they come at different rates and different intensities for different people at different times. And without the ability to monitor individuals for an early detection strategy for urinary tract infections, one of the more common causes of hospitalization and rehospitalization in our health system, which is urinary tract driven urosepsis, and can be much more effectively managed and addressed, as opposed to what we typically would, without these tools, would be faced with, which would be perhaps a late phone call from a nursing home, perhaps a late notification from a family member or friend who notices a change in mentation or mental status or general condition of the individual with that condition. So having a well thought out sensor strategy for optimized RPM is absolutely going to be part of our future. We're in the midst of implementing it as we speak, and it's exciting.
Yeah, I think that the average person doesn't really realize just how far down the line we are. I mean, ultimately, and I talk about this in some detail in the book, but ultimately we're going to monitor 20, 30 different biosignals with a combination of an in-ear technology and some adjuncts. And then, of course, they'll be prescribed wearables based on known medical conditions, right? So essentially, that patient is in a situation where it's even greater than being in an ICU. They're getting more continuous data sent to the machine than they would in a normal acute setting. And that information will get looked at by artificial intelligence to determine what exactly the course of action is. And I think ultimately part of that has to be around care plans. I think that sending people back to their primary care doctor may not be the strategy that this method ultimately follows. It may send them directly, if it's emergent, send them directly to somebody that could care for them without delay. I think there are abilities to leverage game mechanics, social engagement, social collaboration, some of these other tools also to help them comply to wellness and preventative regimens. One of the things that we talk a lot about in the film is the importance of reestablishing a relationship with the physician and the patient in a way where there is better freedom to operate, especially in the area of focusing on prevention and wellness. The problem that we have is that the economic incentives that have been created in the machinery of healthcare punish prevention and wellness, and they reward gratuitous intervention. And I think until we change those economic models, we're not likely going to have drug companies, device companies, even hospitals and clinics, and in some cases, physicians really change behaviors. It's just somebody comes in, they're 35 pounds overweight, they're hypertensive, they have a wide range of other problems associated with that. The physician is typically going to dart them with some prescription because the reality is we know we could affect a positive change through weight loss. But where is the incentive? And that's a big part of what we talk about in this film is, can we change the economic models? We've been inventing around the wrong things as we transition from modern medicine into this next phase. What does prevention mean in your practice? Is that something that you're able to realistically fold in given the time constraints and the economic models?
Well, the strategy of prevention really looks like this when it's facilitated by a digital platform, and again, appropriately deployed. Goes something like this, that the patient seeks out a care team, a leader of that team, which is typically a physician or a mid-level practitioner. And from that point forward, the leader of that team then can apply the offering, if you will, 24/7, 365 to that patient through starting with a patient portal. My experience has been that's an important component of what we call telemedicine. It's essentially the audiovisual platform that is the underpinnings of which are digital in nature, so that for all of us, both as providers and as patients, prevention of disease and or restoration of health and or reversal of diseases and condition, should be our focus, at least at the primary care level. And starting with a portal that is designed to facilitate an always-on environment, whether it be in real time or asynchronously delivered. Patients sending messages, non-urgent messages that are triaged and managed by a team on the provider side, gets us started on the right track for how to leverage a digital platform toward health and wellness, and at the same time build a bridge for a rapid response capability of the clinical team, appropriately reimbursed and incentivized, of course, right, to be there for that patient, and or particularly in pediatrics and or geriatric medicine, the advocate for that patient. In many cases on the geriatric medicine side, some of our better examples of how to make a difference for a client is interacting with their family, their caregivers, if they're in a facility staff, etc., that really identify the opportunity to communicate directly in real time, kind of like the classic kind of live telemedical encounter, but more so asynchronously, delivering information, data, photographs, lab results, status reports that may not be considered emergent, but have an importance and a necessity to deliver that information to the leader of a team that's been identified and been incentivized to be there 24/7, 365 for that patient. Because without that, when things go sideways in medical care paradigm, typically if not designed to address issues appropriately and timely, that's where we find our emergency rooms become crowded again, and the readmission rate to hospitals goes much higher than it should.
Yeah, you know, absolutely. Rich Milani from Ochsner Health System, their chief transformational officer, really a bright guy. He did a program, gosh, years ago with Apple. I think it was 5 years ago now, where they used just an Apple Watch to report back blood pressure readings and a few other things. And through a very cryptic system by our standards today, and this is just 5 years ago, he was able to reduce readmissions in the hospital by 50%. And it was really interesting. And of course, now Rich is on some really other amazing products. He's a cardiologist by training, but he was able to realize that here are the things that we can monitor. If these start to go south, we need to intervene. And I think that's the beauty of continuous monitoring, is if you look at it from a purely economic perspective, we can find disease processes and problems well before they become symptomatic, well before they become expensive. And from a quality of care perspective, we can leverage connected technology and AI to be able to deliver a far higher degrees of safe and efficacious care. I mean, just last week, my car told me that there was a recall notice on my car and told me to go to the dealership. I mean, it's talking to somebody, you know, and my wife's car the other day was giving her all this rich information about when her next service B was due and everything, right? And so it doesn't just look at the miles like you would used to think. What it's actually looking is how you're driving your car, the patterns of how you drive your car, what it anticipates the need for that car to be healthy in the future. And something as cryptic as those monitoring systems are having a credible impact in automotive prevention. Why can't we do that in healthcare? And of course, the answer is we really, truly can. Well, listen, we're so excited that you chose to be in our documentary film, Fixing Healthcare. I know that your contribution will help us do something that really is what the film is all about. And that is to change the conversation. Can we improve the relationship and that coveted time that doctors and patients need to be able to reestablish? Can we stop having the machine run the relationship and let the caregiver and the patient run the relationship? Can we stop talking just about the access of healthcare and start talking about something that's far more interesting, and that is the access of health? And, you know, we talk about underserved communities and their inability to get access to health. And that's rural communities and inner cities. Everybody wants them to have medicines, but we haven't really had robust, deep discussions about quality food and prevention. And I hope that our film will have some impact in at least changing the dialogue from this old-fashioned, let's make more medicine, to what we believe the fix is, and that is to have more health. What would you say, and as we close up, would be the big fix? If there is one thing that we could do to fix healthcare, what would that be?
You know, having a philosophy of reengineering healthcare based on focusing on the team-patient relationship on a platform that most of us are quite comfortable with using, as well as our patients, that always holds high as a priority the relationship component of medicine. And with the platform there to help us in the background, kind of under the hood, if you will, that's always dependably monitoring the status of our clientele and our population so that we can really deliver care and or receive care with a sense of security and confidentiality, as well as confidence that we're being managed by a team that cares, knows what they're doing, is well trained in the core principles of how to use technology to, again, deliver care in a personalized fashion. We're headed toward that. There are some forks in the road. We need to be careful about taking the fork of commoditization of data and having the incentives in that process go in the wrong direction. But I think the crisis that we're currently still dealing with is it has the silver lining of pointing us in the right direction.
I think that's right. Well, listen, I know you're busy. I really appreciate you taking the time to share your ideas with us. Again, we're so excited to have you in the film. And thanks again for joining us today.
My pleasure, Nick.
You've been listening to the Healthcare Cure podcast. Don't forget to visit our website at thehealthcarecure.com. And thanks for listening.